When I started at St George's, it was the year that there was rearrangement of cancer services. So I was to effectively take control of the benign side, which is, so we were allowed pretty much to focus on developing bariatrics and benign surgery. So, and I think reflux and hiatal work is an essential part of any benign unit to develop. So we've reached a point now where we have 3 MDTs a week. One for the cancer patients with the oncologists and radiotherapists, and we link with the Marsden. All the resections are done there, and locally we have our MDT for bariatrics, and we have an MDT for the non-bariatrics, which is predominantly reflux and hiatal work with the gastroenterologist, physiologist, and physiology technicians. So my thoughts were that we should try and be able to do the whole range of procedures to give a balanced view. I'm not a fanatic on one particular procedure. I'd say that depending on the time of year, I end up being a Stretta man, then I become a links man, I become a fundo man. And between the 4 upper GI surgeons, I obviously tend to do more of the links and Stretta at the NHS, which wasn't straightforward in getting agreement to proceed on the NHS. Obviously, as the private's a little bit easier from the funding point of view. So really, when we were sort of setting down that pathway, I mean, fundamentally, there are 2 assumptions that I think a lot of people have in the medical world as well as the public, is that they're either tablets or a fundoplication in the form of a Nissen. And I think that because people have become much more concerned about taking long-term PPIs, and there's a lot of sort of internet volume of concerns being raised, we're seeing a lot more people coming forward and saying, what are the options? And it's really clear to me there is no perfect option. And, whether it's what type of fundoplication, whether it's links or Stretta, it's still not completely clear. I think they all have a very important role because none of them are perfect. And, we know from the surgical side that, there's obviously very high quality work being done, but that there is a range of risks and complications occurring in traditional fundoplication. And there's the issue of satisfaction with it, and there's the issue of durability of anti-reflux surgery. It's really not, as years have gone on, people are more accepting now of revision surgery as well, I'm finding. So I'm doing a lot of revision work where the fundoplication was extremely successful. But I think that what we do need to evolve is a balanced view that many of these techniques have a role. Some have come and gone. I'm sure you're aware of some of the endoscopic techniques, but I think that Stretta got off to a bad start because the company, after a few years, when it first started, the first generation vanished, and when it came back in, it was seen by many as novel again. But actually the data for Stretta is really quite substantial now. And many patients do want a non-surgical approach, but I think it's not appropriate for all patients. Most of us know that obviously if you have a significant hiatus hernia, maybe bigger than 2 or 3 centimeters, endoscopic techniques like Stretta are not so good because there's very little anatomical correction of anything beyond the lower esophageal sphincter with Stretta. It's a very straightforward procedure. I mean, I'll talk a bit about selection later, but it's fairly straightforward to learn and perform. I do it under general. Louis de Guerra at Turin, who showed me how to do it, does them under sedation. His patients seem to lie very still, and they used they used remifentanil, but my anaesthetists are less able, I think, to, or our patients are slightly different in their anxiety levels, perhaps, but they tended to move a bit. So I found it much easier just to do it under a general. They can still go home the same day very easily. And it just involves a balloon with some needles in, a frequency generators, a box a bit like a harmonic scalpel box or diathermy box, and allows you to place the radio frequency into the lower esophageal sphincter level, which you've initially inspected with an endoscope. So there's definitely, it's a short learning curve, and quite a few people have come and seen, and I've gone on to watch them, and they're active now doing this procedure across the country. So how it works is still slightly mysterious to me. I don't think anyone really understands, but there's clearly objective data to show from EUS and histological data from pigs and things that the lower esophageal sphincter does at least thicken and hypertrophy over time with this radiofrequency. The Americans are doing Stretta for the second time now, which seems to be giving some quite good results. And some patients are saying, well, look, it worked really well for a couple of years. It's definitely not working. Can I do what the Americans have found seems to help? Because clearly it has durability issues like all techniques. I mean, the data is fairly strong now. I mean, it's been looked at by most of the American sort of endoscopy and GI associations. And, you know, it has, at least in the short term, very good outcome data to say it does improve reflux symptoms and quality of life. I mean, there are lots of different ways of scoring it, we know. So some are based just on reduction of PPIs, some based on the quality of life surveys, but overall the satisfaction rate definitely is good for Stretta. Long term, I think there are durability issues. I was always very surprised with when I talked to Luke Degira how convinced he is about the more than a decade positive outcomes, you know, the durability, but because I'm personally not finding that. But I mean, I'd say that probably about a quarter of my patients within a year or so have had a really good result, and within 6 months to a year, quite a few of them are saying to me that, you know, they think it's wearing off. I mean, I've been doing Stretta now, well, Link's probably about 6 years, maybe 7, fairly early on, and then Stretta privately initially, probably about 4 years or so, maybe a bit longer, and on the NHS for about 2 years. So our audit isn't complete yet for our data, partly because of COVID as well, because our funding relies on our audit outcomes with our, so which we have to present to our board. It's fairly expensive. It costs the same as an operation, Stretta, fundamentally. The device is almost £3,000. So they're happy for us to do between 20 and 30 a year, but COVID stopped our second year. So we're still waiting to get the numbers. But I think there is more of an issue with durability with Stretta, in my view. And it's patient selection, clearly, as with all procedures, really important. But up till sort of 2015 or so, already there were, you know, many thousands of Stretta procedures. The Americans, once it was FDA approved, have pretty much taken control of the volume, and it's just arrived in India. So I think we'll see a lot more data soon rather than just the European studies. But SAGES have looked at the available data up to 2013, were very positive and confident with its role in managing reflux. They gave a very strong recommendation. They haven't withdrawn it. I think the data that's been developed since then has only supported that. And also the ASGE in the US also feel it has a role and should be considered. So I think that there's a place for it. It definitely, you know, up till a couple of years ago, there weren't many randomized trials, but they are coming forward now. And the observational studies show it to be at least as effective as in the short term as funded application with lower adverse events. Clearly, it's not suitable for all the patients that a funded application are suitable for. So it's still a relative niche compared to fundo, which could be effectively universal almost. But the adverse events rate is very, very low. And I think that that's a real concern for many patients. I think the internet obviously raises their concern even more because of some of the you know, sort of chat rooms and forums that they go on. So the sort of patient that I would look at for a Stretta is, firstly, I always discuss with them the whole range of procedures, and it's not always suitable for all of them. So if they have a bigger hiatus hernia, between 2 and 3, I'd discuss with them that I think it's a weaker procedure than the others. But it is potentially an option over 3 centimeters. I'd want to accurately know it really is a 3 centimeter hiatus hernia. The endoscopy appearance can be fairly unreliable, I find, when you're looking at differences between a quoted 2 centimeter on endoscopy or someone who says it might be a 4 centimeter. So sometimes I'll do a limited CT across the diaphragm just to look at it, or barium, just to establish the size. And the patients still have all the same workup as any other anti-reflux patient, and we discuss it in our MDT with our gastroenterologist. I do warn the LPR patients that we're looking at about 60% success in managing their symptoms. The LPR patients will always have gone through ENT as well. And I'm always really cautious with patients who have burning tongue syndrome and things that I don't really understand. There's some patients who've had Nissens who, there's very little data on this, but they're keen to have something and their medication isn't sorting it out. They don't want revision surgery. I may consider that. Similarly with sleeve patients, I've not had success in this bariatric sleeve patients. It was very hopeful at the beginning that bariatric patients would respond to Stretta, but I think with sleeve, because it's quite high pressure, the system, we're not going to see good results for it. And with bypass, I think that, you know, it's very common to have reflux even after bypass, probably slightly more in sleeve than bypass, but I'm not confident that it works. And I think that a lot of them have got hiatus hernias in bariatric patients, especially when they lose the hiatal fat, it becomes more apparent. So we tend to surgically repair them. The lung transplant patients, very interesting. I've started a Harefield list. So I've done a list already there on patients. They're worked up by the Harefield team who do pre and post transplant pH manometry. I had no idea. And basically, the Harefield Brompton, they've been having a lot of problems because of the reflux increasing the failure rate and the mortality rate post lung transplant. So they've been collecting data on pre and post pH manometry for these patients. And traditionally they went for fundoplications, but they've had a lot of, they find that in this group of patients, they don't tolerate it very well, the side effects. And so we're now considering other options. So we have an MDT and we're discussing, I've done one list actually, it wasn't Stretta, I think it was links, but every 10 weeks now, I'll be going to Harefield Brompton and doing that anti-reflux list. So it's an interesting thing because I think that anti-reflux surgery is becoming much more acceptable. We have got some patients we're going to use Stretta on who haven't got hiatus hernias, but a lot of them I think are getting diaphragmatic compromise as a result of their surgery. That's what it looks like. I don't know if it's neurological from some sort of from the actual surgery or whether it's muscular sort of interference during the lung transplant, but there's clearly some disruption of the hiatal area as a result of lung transplants. It's mysterious to me. But they do get a lot of reflux and that leads to mortality very clearly in their view. There's some patients I wouldn't do it on. I mean, we're not doing under 18s. It's not, there's no safety data on it, so generally avoid. Patients who don't have a clear diagnosis, I think they should be worked up exactly, you know, good motility, good DCI, all the same reasons that, all the same criteria as any other procedure. And I think that I have done it on some patients who are poor surgical candidates, in fact, and that's, you know, patients with lung disease particularly. So where does it fit in? Well, I don't think it's one or the other. I think that, you know, in my view, if they were suitable in the ideal world, where you could do it, everyone would get a Stretta, and there's a chance that you would save some patients going to surgery, but there are clearly some surgical patients who are not suitable for Stretta. I think it has a bigger issue with durability. I think there's a bigger failure rate for LPR patients without a doubt. I think that how you interpret success is really important because after Stretta, I would say that there are more patients who don't totally come off PPIs, but their quality of life is much better. Some of them are still on intermittent PPIs. It doesn't work, I don't think, well in bariatric patients, particularly not in sleeve patients. So I think that it's just one of the options. I think that if we had a free hand, I would, on quite a few of my surgical patients, give the Stretta a go if I had an opportunity, and it may save them an operation. They may end up having one because of the durability issue, but we know there's a durability issue with fundoplication as well. So I just mentioned the bariatric only because a lot of our patients long-term in bariatrics do get reflux, and I think that on the sleeve patients, we often do a hiatal repair and bypass them, and I'm not doing Stretta on sleeve patients now. I just don't think there's the slightest response. So this is sort of how I view the sort of range of procedures that I do, who I would operate on and what technique. I haven't really mentioned bypass, but obviously patients who fulfill some bariatric criteria as well, even though you do the lighter weight, without a doubt, would consider doing a bypass on them. But the Stretta, I think those who can't have surgery or won't have surgery, there is a group there. Patients suitable for the other procedures are also generally suitable for Stretta unless they've got a big hiatal defect. And I think a particular group of these lung transplant patients. Some questions.
Marcus, thank you very much. That was it's fascinating to hear your experience. Just out of interest, how many Strettas have you done, do you think now?
About 70.
70. So, I mean, I think that that is probably the second largest series in the UK, isn't it?
Yeah. Only about 20 of them in the NHS. And it took a while to get it introduced. It's been quite a big hurdle. So we need 2 years of our numbers, so we need to hit about 40 or 50 before I report back to the funding body to get to see our data. At the moment, I've had to be quite strict on patients in the NHS because I don't want to pick patients where I feel there's a lower risk, lower chance of success. Yeah. So I'm very careful with the LPR patients in particular.
So I've got one question, and then there is lots of people, lots of questions. But I mean, I personally am persuaded that, if patients have got a hiatus hernia, then that's likely to be a significant contributor to their symptoms. And you know, we know, don't we, from manometry, that the contribution of the crura to the LOS is significant. Probably about half the pressure exerted by the LOS comes from the crura. So it's I'm just interested in your. What I would challenge you is a slightly arbitrary cutoff of 3 centimeters for a hiatus hernia. Personally, my view would be, I don't quite know how Stretta works, but I can see that it would have more of a likelihood of success if there is no hernia. But if there is a hiatus hernia, I would say I can't see the point of doing it. So, I mean, the question is, do you have any data to support that 3 centimeter cutoff? Or is it just that sort of your anecdotal experience, or for that matter?
No, it was basically a bit like putting the. I think it's a bit like the links inside the vagus from Demista. It's sort of how it was done at the start, and the principle is you're saying that your instinct is that hiatal weakness and defects are not going to fare well and get a good response with Stretta, and I would fully support that. So that's part of the reason why I think that it's worthwhile having a range of options for the patient, and that there shouldn't be a Stretta man. In the same way, there shouldn't be just a fundo man. I think these are all things to discuss in the MDT about suitability. So I think I agree. I mean, ideally, I wouldn't Stretta anyone with any hiatal weakness. Sometimes, as you know, even in surgery, you discover the weakness is bigger than you think. And I suspect that some of the failure in the Stretta is because they have crural weakness or defects and hernias which we didn't know.
Yeah. So let me just run through some of these questions. So Adam, he asked, is there any controlled evidence using Stretta in patients with regurgitation as opposed to non-regurgitation?
No. I think volume reflux is an almost slightly different category than patients with classical reflux. I'm trying to avoid LPR patients in Stretta. I think that patients with, if you think proximal reflux and high volume reflux or nighttime reflux, it's really clear to me that Stretta can't replace any of these surgical procedures. But I think that there is a group where they get benefit, and it can last quite a long time, and it might avoid them having surgery. It might delay their surgery. It might avoid the dosage of PPIs. But I think for regurgitation, it's unlikely to work, and there's no strong data saying it does.
Okay, that's great. So from Simon, I think you did, obviously at the end of the talk, you did talk a little bit about the role in bariatric surgery. But he did ask, do you have a feel for what patients are suitable, most suitable, that you might consider Stretta on? I got the feeling from your talk, not really any of them.
Well, I think that patients with heartburn symptoms, minimal or small hiatus hernia, needing long-term PPIs, good physiology, I'd be happy to do a Stretta on. Patients with really curious type symptoms, I would be concerned about. The ones, as you know, with all sorts of different mixtures of headache and water in the head and their tongue hurts and the sort of wider range of symptoms, I'd be really careful. But at the same time, you have to think, what is the downside of Stretta? Besides, obviously, having a procedure, but it's incredibly low risk. I mean, it's just a fraction more traumatic than a normal upper GI endoscopy. So that has to be balanced. And I think part of the appeal of Stretta is that it doesn't have the significant downside, which if you're unlucky with surgery, it can. So I think that Stretta's role is enlarged because of its low comorbidity, low complication rate and side effect rate. Even though I'm skeptical on its long-term durability.
So I think you partly answered. Peter asked a question with regard to whether Stretta makes subsequent surgery more difficult. In my experience, I've done quite a few patients who've come following Stretta and then had a fundoplication or links, and I don't find it any more difficult than where it's sort of virgin esophagus. Have you a view on that?
Yeah, it's there's no aftermath that you can see at laparoscopy at all. I think that basically, from the point of view, I've just seen a question from Shamin. Durability, I mean, I quote 60% improvement in LPR and about 80% improvement for classical reflux symptoms. Concerning durability, which is what she's asked for, I usually say many years, but I doubt very much it'll reach the published success rates of up to a decade, which even a fundoplication has durability issues at a decade significantly. And so I think it's unlikely that Stretta reach that far, but it's clearly years in the patients where they do respond.
Yeah.
And that's enough for many. I mean, the Americans are doing it a second time now. And given it's a super low morbidity procedure, it's quite acceptable to most.
So it's interesting. Anthony asked a question which is potentially of interest, which is that actually the data regarding post-operative acid exposure is that it's still pretty high. So, and I think some people do think that the way Stretta works, or it might work, is by effectively denervating afferent input, if you like. So patients still have reflux, they just don't, but they don't, think they do. They don't appreciate neurologically. Do you think that's right?
I don't think we really understand quite how it works at the moment. I mean, from the point of view of why you get hypertrophy of the lower esophageal sphincter, we don't understand why that happens. Does it denervate? Well, I mean, at the moment, all the studies are ultimately pH manometry and histological and endoscopic ultrasound from the point of view of looking at the sort of anatomy and neurophysiology. So I don't think we understand how it works. It's just that it's become quite a long-standing procedure now, well over 10, 15 years, and we can see the outcome results. But a lot of the studies don't conclude of what the mechanism is on why patient symptoms improve. But there are lots of data which says that the acid reflux is actually reduced and the increase in lower esophageal sphincter tone. It's really complicated, as you know.
There was a question from Jordan regarding your preoperative manometric workup.
Yep. Sorry, did you ask me if I do for Stretta?
Yes, I mean, do you
yes.
do you do it, and for what reason? I mean, are any specific manometric findings that would exclude?
Well, I would like still to see a patient who has good symptom correlation, a good DCI, sort of minimal failed peristalsis. if this patient does not respond, and we repeat the pH manometry and we're heading towards surgery.
It's very frustrating. I don't know if everybody is in the same situation, that he's just about to give us a pearl of wisdom and freezes. Oh, he's gone completely now. I think we've lost him.
Hi, I'm back.
He's back.
I'm back.
He's back.
Hi, sorry.
We missed those pearls of wisdom.
Yeah, I'd like to have a patient with similar pH and manometry results as I would for surgery. That's the ideal. I mean, I do compromise because it is Stretta and the downsides are minimal. But if I can have pre-operative pH manometry showing good peristalsis, good DCI, good symptom correlation, all the standard features that we'd look for, that'd be ideal. Because in the back of my mind as a surgeon, I always think if this doesn't work, we're heading towards an operation. So to have a baseline pH manometry study prior to Stretta, I think is really useful.
Yeah. So quickly, two more questions. Firstly, Ahmed, I think that we probably know the answer to this question on the basis of what you said, but he asked, does the damage to mucosa make neoplastic cellular change more likely, at least theoretically?
I don't think we know either way. It leaves a minimal visible and histological change from the point of view of abnormal cells. And the only histological changes we've found they're all pig studies where they've chopped it all out and they've studied it for, but there's no suspicion on those studies of long-term abnormality except the hypertrophy and increase in thickness and pressures. From the point of view of visible on endoscopy, there's nothing visible when you re-endoscope them. And laparoscopy, you see nothing across the other side of the esophagus. So unknown.
So something else that's unknown, my personal suspicion is that the way Stretta works when it does work is just that business of increase or decreased compliance of the distal esophagus. I mean, we know anecdotally that when links are explanted, about 50% of people have continued reflux control. And that's probably, again, down to the fibrosis and associated reduced compliance. So that may be the reason it works.
Yeah, I mean, on the Stretta, they did a study where they infused sildenafil to relax the muscle, and they showed that even in successful Stretta patients, there was a full relaxation. So I think they tried strongly to show it wasn't scarring, because that was always a concern to people. So the sildenafil study effectively showed a fully responsive relaxation in the lower esophageal sphincter, which, shows there's no significant fibrosis or sclerosis or cellular change that would restrict function of that bottom end of the esophagus.
Interesting. So the one final question, which was from Peter, and he says, does Marcus have any experience with Stretta in patients with chronic respiratory disease and reflux aside from lung transplantation?
Predominantly lung transplantation is other patients being sent to me. I have done very bad COPD patients. I can only remember one, and actually a year later, unfortunately, he died. So I never really know his long-term outcome, but from the reflux. But the problem is they refer them quite late, and if they're not fit for surgery, it means they're usually pretty grotty. So I think not enough numbers to draw any conclusions.